Robert. Oh, can't hear you. Hold on. That might be me. Hey, Doug. Welcome.
Hello.
Robert, can you hear me okay? I did not hear you if you were talking. You might have been muted. Oh, still muted. Let me see if I can unmute you.
I just unmuted. I was talking on the other line.
Oh, okay. It looked like you were talking at us, so I could see your mouth moving. Great.
No, sorry.
No worries. I can see you and hear you all both loud and clear. I'm going to step away for just 1 minute while we wait for folks to join. And we have one other panelist joining us today, but I see attendees are already starting to roll in. So I'll be right back. Hi, Dave.
Good morning. How's it going?
Doing well. It's a Friday. I can't complain.
Right. Well, we can always complain. I just don't know whether
That's
it does
true.
any bit of good.
Well, and I'm certainly not having to put out any fires like all of you, so I guess I'm grateful for that.
So last time, my signal gave me a little trouble during my panel discussion with the American Cancer Society. I am hoping that it doesn't do that again. It's interesting with these new computers, they don't have the direct sort of ability to connect to the Wi-Fi or have a direct connection, and so I was hoping I could do that, but my computer doesn't even have that port anymore. So we'll see how it goes. If I have to scramble and move, that's probably the reason why. But I am literally sitting right next to my Wi-Fi connection, and so I'm hoping that it does not give me any trouble. So
Yeah, I've had to move to using a docking station for that reason. My laptop also does not have an Ethernet connection.
yeah, it's really interesting. I thought I had an adapter to do that, but yeah, I'll have to look into that.
Hi, welcome to everybody who's joined. We'll be getting started right at noon. Please do feel free to pop any questions you all have along the way in the chat or the Q&A, and get started here in a few. We had over 40 registrants for this event. Some folks have requested for us to send the recording out to them if they weren't able to attend. So we are recording. Hi, Eric. Happy Friday to you also. I'm going to give folks till about 2 after the hour just to catch any last minute stragglers if they're anything like me who have technical issues on every single Zoom call.
Hi, this is Angelica.
Hey, Angelica. We're just waiting until about 2 minutes after to kick off. I'm looking to you to help me man the chat and the Q&A today.
Oh, gotcha. Okay.
All right. Well, actually, let's go ahead and get started. I'll do my little intro as folks are still joining. But welcome, everybody. Thank you so much for joining us today on a Friday for an hour and a half over your lunch to hear about emergency response. I'm really excited today for our expert panel. We have some trendsetters here who have graciously volunteered a whole hour and a half of their time, which right now there's all these new surges and emergencies that are happening daily that these folks are directly either responsible for or overseeing. So huge thank you to our panelists and guests today. With us today, we do have Doug Johnson, Director of Quality at Lovelace Medical Center, registered nurse, CPHQ, and Lean Six Sigma Black Belt. So he is a data champion and a process improvement expert with over 28 years of experience optimizing processes across just about every domain. We also have with us today Robert Perry, the Director of Emergency Preparedness and Dispatch Center from UNM Hospital. Also with formal education in nursing, actually forgot to mention with Doug, yes, registered nurse. Robert, also with formal education in nursing, certified emergency nurse, in fact, with particular expertise in disaster medicine, which I find really interesting. You don't hear about a lot, in emergency management, which he lectures on and writes about both locally and nationally. So welcome, Robert. And last but not least, we have Dave Panana, who's the Chief Clinical Operations Officer of Kiwa Pueblo. And he's bringing the voice today of rural healthcare to the mix. He also has a formal education in nursing, which I didn't find out all three of you did until just today, so that's great. And Dave also has many years of direct care. He's moved since into administration and has continued to serve in those roles, particularly around administering and managing 638 tribal healthcare facilities. And Dave also serves as the Albuquerque rep for CMS's Tribal Technical Advisory Group and is the chairman of the Behavioral Health Subcommittee of that group as well. So really accomplished guests and speakers today, really excited to pick their brains. Today we're gonna mix it up a little. We're gonna start with 3 micro presentations. It's about 7 to 10 minutes each from each of our panelists. Give them a chance to share some of the in 10 minutes, share some of the COVID challenges that you've had and that you've encountered. And then, of course, how your organizations have responded, just to tee up the panel and the conversation that we'll have. And, I've asked them to share some lessons learned, and we'll have a chance over the hour panel to deep dive and ask them more questions that they've mentioned, anything interesting that we want to talk about. So then we'll do, after the micro presentations, we'll do about 45 minutes of panel discussion. So please, please, please feel free to send any questions you all have to us in the Q&A box or in the chat box, either while our guests are presenting or during the panel, and we'll want to be sure to ask them while we have them here for an hour and a half today. So with that, we're going to kick off, and I will hand it over to Doug to kick us off, talking about the COVID testing that you all rapidly implemented, the first in New Mexico and one of the first in the nation. So huge congrats.
Thanks. So talk about challenges in 10 minutes. We could probably write books on this. Thanks for having me. Can you see my screen with the PowerPoint?
Looks great.
Okay, great. So I'm just going to jump through a few things real quickly. We were asked to talk a little bit about the evolution of process improvement as it relates to the drive-through testing that we did. So I'm just going to jump through some slides fairly quickly to give you kind of a background of what we've done. But we started a drive-through testing. It was a Wednesday we were asked to do this. We had it up and running by Friday, so 2 days later, and a lot of evolution as we went through this process, and some of the other things that we did as well with COVID. So the rapid deployment activities, this is some of the people of the team. We had a good old time out there starting out. It doesn't look quite so happy today. People are getting a little tired, but we quickly just threw a napkin type of exercise together to look at the process and what the drive-through would look like. And that's just an example that I'm throwing up here on the screen. And then we quickly went from there and drew out what it would look like. This is our makeshift drawing, if you will, when we first started with this process and how we were going to bring cars through a process to do screening and the logistics that we needed to do that. So the steps were really to identify every role in the process that we would need. So nursing, screeners, we would need all the maintenance pieces of it with generators and everything else, but we identified every role. Then we created standard work for each role. I've only got 10 minutes, so I can't talk about all the details of process, but standard work is critical in this. And then assigned a trainer to train each morning. So as people showed up every morning, we had to do a lot of training every day for each one of those standard work roles and tell people exactly what they needed to do, all the way down to how you do a nasal swab. Assigned, and then we did daily huddles every day, before and after actually the day, so that we could talk about our lessons learned. Team leader to manage the changes, on the fly, because we were making a lot of changes on the fly. Over to the right, I just have a little picture of what that standard work kind of looked like for each role. So starting out, we went to this. This is just a slide presentation to show you how we went from this process, and then we converted to this process, and we converted to this process, just to show the evolution and how things had changed throughout the days. And what we were doing is we actually had process folks that were out there. Steve Griego is on my team. Got to give him a big kudos, who actually watched and looked at cycle times as we went through the day, so we could determine how we would flux and change things. So lessons learned. Spend the time to plan and document the process. A lot of people through this COVID pandemic are thinking that we don't have time, we just have to go get something done. You've got 15 minutes or 30 minutes to sit down with the right people and at least draw it out on a napkin. So it's really, really important that you do that. Monitor cycle times in the process real time and adjust. You can predict and you can plan as much as you want, but you cannot predict and plan for some of the human factors that are involved with a process like this. So you have to engage while you're doing the process and change things. Follow-up patient calls for patients. This was a lesson learned. Okay, yeah, so we're going to test, a couple thousand people right away the first week. How are we going to follow up with these people? Are we calling them back with negatives? Are we calling them back with positives only? Who are you calling? We didn't have a call center. We set that up. Everything else along with that. Training for the swabbing procedure every day. You think, oh yeah, give it to a nurse. They know how to do a nasal swab. Yeah, no. You have to train people every single day and show them the procedures and how you want to do that. simple one, generators. The first day we need extra gas for the generators. Nobody thought of that. So as the generators are starting to crash and the computers are crashing, we're running around looking for gas. And weather, of course. We do predict the weather here in New Mexico pretty well, and we do have pretty good days as far as weather. I'm from Wisconsin, so I can't complain about the weather in New Mexico, but those changes have really impacted our processes as well. So other rapid improvements, I did have to throw this up. Lots of things that we've done over the last year. I just threw a few things in. I'm sure I'm missing a few things, but the COVID preparation plan, that by itself, we started that in January with standard work and processes. System-wide COVID reporting processes. Don't get me started on reporting, but that's a huge, huge issue, and lots of labor costs to do that. We found some automation in doing that, and we were really working to improve those processes. But supply calculators, this is an interesting thing, and I can't spend too much time on it either, but one thing in healthcare that's interesting is we don't really match our production with supply very well. If you're building cars, for example, and if I was going to build 50 cars today, I would know I would need 200 tires and rims, right? In healthcare, how do we match the production with COVID, for example? And so we can't do that. And what we learned was you can't do that on historical evidence because COVID changed everything. So if we have 10 COVID patients, how much PPE are we going to need? It all is dependent on the processes that you put in place. Mask fit testing, mask filter life management process we put in place, a process for that. Contact tracing processes, we have processes for those. Employee screening processes, results callback processes, elective procedures for COVID testing processes, design and implementing separate respiratory emergency department, employing surveillance testing, and social distancing design and plans for all areas. So just a few things we've got tons of processes on. We did this big, and I'd be remiss if I didn't throw my team up here. This is my team. They're an amazing group of people. Every one of these people in this picture started doing work that they've never done before. And we did this huge campaign called the 23,000 Lives Celebration. And this was a few months ago. We're way above 23,000 lives, but the lives that these people have touched through COVID, through testing, through callbacks, through infection control, everything else. So don't forget to celebrate. But then in summary, the three most important things to have in place to respond to crisis quickly: staff preparedness to mobilize and transition quickly. That's really important. Disaster drills, but not just the drills themselves, but use the actual equipment, because that equipment, you'd be surprised what it looks like PAPRs and everything else that's been sitting in closets. So clearly define roles and responsibility, and I actually said of leadership. And this is important because all leaders want to jump in and take control. Let's figure out who's doing what and make sure that they have their roles and responsibilities defined. Your biggest lesson learned, what you would have done differently. Planning, get everyone on board to ensure that they agree on the plan before implementation. So I talked about that early on. You've got enough time to plan, even if it's 15 minutes, but we made mistakes there, of course, and didn't get everybody involved that we needed to. Foundational elements of management. So I'm a firm believer in defining your processes, having standard work, having employee engagement through, and I don't have time to talk about it, but the lean principles, the Shingo model principles, very, very important. If you have that basis in place, you'll be prepared for anything in the future, but not everybody is there. We weren't there either. Largest challenge for going forward, staffing. People are burned out right now. They really, really are. And I think everybody on this call will know that and recognize that, but it's a really tough point. And then opportunities related to the crisis. The initial breakdown of the silos and the barriers to get things done. We work together to achieve a common goal. This is one thing that I would say that COVID did for us. And I put these little firefighters on the bottom here for a reason. You never see in an environment where there's a fire, you don't see firemen looking at each other going, no, it's your job to go up and save that little girl on the 4th floor, do you? They just get it done. You don't see the Navy or the Marine Corps standing in a battle zone saying, listen, this isn't our job. We're going to turn around and walk away. This is Navy's job. No, they get in there and do it. So what we can learn from a crisis standpoint is that we can all work really, really well together to get something done. So if we as an organization set up what our common goals and our strategies are as an organization and engage our people to mobilize towards those things, I believe there's not a single thing that we can't achieve. But that's a really critical message for leadership to understand how to set those strategies and goals and mobilize their staff towards that. I think we can learn that from COVID because we were able to do that. And then transparency of the need to develop standard processes. So I said that probably over and over again, but that's critically important. So that's hopefully less than 10 minutes. Thank you.
That was wonderful, and now I have so many questions about what you presented. So it's great. No Steve today. Tell him we said hello. I was hoping he'd be able to join us as well. No, that's great. You all have done some amazing work. I'm excited to dig in a little bit about some of the details when we get to our panel. But thank you for everything that you all have done. All right. With that, let's go to Robert.
Hi, everybody. So I'm going to attempt to share my screen here. So you should be able to see my screen.
Yes, we do.
Thanks, Doug. That was a great summary, and I look forward to asking numerous questions of you as well with some of those challenges you faced. So as Stephanie said, I'm the Director of Emergency Preparedness for University Hospital. So my job entails preparing for disasters and emergencies, and here at University Hospital. So I'm going to kind of take an approach where, let me back up a slide, where we talk about the preparedness and the mitigation efforts that should be undertaken regardless of what kind of disaster or emergency it is, and how it will help you when those disasters or emergencies happen. So one of those things that Doug, I heard him hammer very, very loudly and clearly is planning. And I fully agree with you, Doug, that you always have time to plan. It may be a quick plan, it may be scribbled on a napkin, or it may be a formal plan. But you always have time to kind of plan and map out the processes that you're going to do. And that's what should be done before any kind of emergency or disaster. And that's why establishing emergency operations plans, who does what, to Doug's point, the roles and responsibilities, is how are we going to manage patients during a pandemic? How are we going to get supplies to people? So, one of the challenges coming up, we all know, is vaccine distribution, and not only to staff, and healthcare workers, but also to the general public when that time comes, and surge and business continuity operation planning. So one thing that helps, you're never fully prepared for a COVID pandemic or any kind of emergency as such as this. We've had emergencies in the past, H1N1, we've had Ebola, particularly here in New Mexico. We had rule out patients. We never had a physical Ebola patient, but we've taken those lessons learned from those smaller incidents or from those incidents and kind of been able to build upon how we're responding to these today. Such as H1N1, we learned a lot about distribution and just testing and care. Ebola, we learned a lot about PPE and how to manage that, and also participating in exercises. One of the interesting things that I have to say is Crimson Contagion was a federal exercise that the State Department of Health participated in. It was statewide. And it was this very scenario that we're experiencing now. A little bit scaled back, and the time frame is much longer than 4 hours of that exercise as compared to the 8 months of we've been experiencing COVID. But the how to triage and how to take care of patients during these times, that's what that exercise was designed to do. And it's fresh in our minds because it was only August of 2019 that exercise happened. And then COVID started ramping up in July. Equipment and medical supplies is, not everybody's as fortunate. And Doug touched on this a little bit. It is medical supply caching and how much PPE do I need? Where do I get it? How do I know how much to use, how much to buy? And that's really all, it's kind of, you know, almost to the point where it's a guessing game until you get into the equipment. But that's one thing that has saved us as in this COVID event is that medical supply, that equipment, having that extra stuff. Also, something that's helped us is having pre-established agreements with different agencies, different companies, different, you know, inside the health system, and to really help. I wouldn't be amiss if I didn't add participating in healthcare coalitions. Throughout New Mexico, there are 4 healthcare coalitions in the state that work on specifically bringing together healthcare partners and preparedness and mitigation and working together and knowing each other before a response. And the last one you see that's there is commitment. And it's bold for a reason. You have to have commitment from your organization and from your partners to carry out a successful, whether it's preparing and mitigating against a disaster or having a response to a disaster or emergency, such as COVID. Leadership has to be committed. Staff have to be committed. Folks have to be committed. And I think that's one thing that we have seen absolutely without a doubt is leadership's committed, staff are committed to that. So as here at University Hospital, specifically how we responded to the COVID pandemic, you know, we started meeting January 27th and putting a planning group together and pulling out that pandemic plan, dusting it off, looking at things, where can we surge? How can we take care of patients and things like that. It wasn't until March 5th that, so we conducted regular meetings from January all the way till March 5th when we activated our emergency operations plan and started meeting regularly to manage the incident. And so we kind of had that month jump to really help plan out, okay, if we get a surge in patients, where are we going to put them? How are we going to take care of them? Where are we going to get the staff from? What's looking like it's going to be the worst? And then the governor declaration on March 11th with the first cases. Some things that we did well early on is, again, that early recognition and activation. And we conducted internal training and exercises as to, okay, the pandemic's starting to ramp up. What are we going to do next? And asking those questions. Communication is something, you're going to see it twice here, and there's a reason for that. Communication, we've done very well, in making sure our staff and folks understand and know the exact situation and where we face and where we're going and what we need to do. Restricting access and visitors, I'll tell you that it's a big campus, it's a big hospital. And that was probably one of the best things that we did was restricting access. So we didn't have so many people coming through all these different doors. We had something like 24 doors, and we pared that down to 4. So allowing a little bit more of control on who's coming in and out of the facility was definitely a help. We established very early on we call the PPE and testing committee, and now we've established a vaccine committee. These committees worked on, what does the science say? What does the literature say about PPE and wearing it and this virus, and what's the most appropriate? What's not the most appropriate? How should we put patients together? Where should we put patients? What kind of things? And then the same thing on the testing side. You know, what tests work? What doesn't work? What's going to give us our best bang for our buck? How much? Okay, we have only this much amount of testing supplies for this kind of test. What's our next options? Where can we get more? How can we get more? So all of those collaborative committees working together with our Emergency Operations Center were great. Increasing capacity to surge in non-traditional spaces so meaning that we converted our clinics to inpatient care areas. We converted some of our pediatric units into inpatient care areas, and the ability to flip those was a tremendous feat. It always looked good on plans and always looked good on processes and procedures. Something that we, again, I heard Doug mention, and I have to give, it was a great early on, is employee contact exposure and force protection. So, okay, we're taking care of these patients. We have staff coming in and out of the rooms. And then mass decontamination and conservation project. We were one of the first, believe it or not, to actually take a look at the literature in the state and say, oh, okay, we can effectively decontaminate masks. Here's the process. Let's see if we can recreate it. And that was a very big help. Some of the challenges, and this, trust me, this is nowhere near the challenges that we faced, but these are some of the big ones. The staff, and I don't think we fully understood the staff and the emotional impact that this virus and this pandemic has had. Staff in PPE for 12 hours on end, they're the only ones in the room when their loved one's dying. Because we don't have any visitors, and we're trying to hold an iPad or FaceTime with folks between the patient and the family, just so they could say their goodbyes. And that not only took an emotional toll, and is taking an emotional toll on the staff, but it's also taken an emotional toll on the community as well. And we're doing our best to kind of overcome that, but we still have staff exposures. And believe it or not, this doesn't mean staff exposures caring for COVID patients is the biggest challenge. Actually, our biggest challenge is staff exposures outside the workplace with this pandemic. Going to Walmart, going to your friend's house, going to a party, having a potluck here at work. Those have been some of our biggest challenges. And again, not taking care of patients because we've done such a good job with our PPE and our protection. But it's outside of work. Adapting to this virtual world, and it's great that this information technology and management, we're all learning to work in a new environment. We're all learning to work. Oh, okay, I never knew that they could probably work from home. What technology do they need in place to work from home? And then I think healthcare in particular, you have to look at, okay, great, we can do telemedicine visits and we can do telehealth visits, but do we have the platforms or the information to be able to do it securely and safely and share information back and forth? So again, that adapting to that world and making sure that you have the mechanisms in place has truly been challenging for us. Data information tracking. I think Doug glossed over this one, but I have to agree fully that data information tracking, it has been one of the greatest challenges is within, we thought we had a good handle on how to track patients, numbers, where to put patients and things like that. But this COVID pandemic has certainly demonstrated that we did not have as good a handle on it as we thought we did. And reporting numbers to the state and the federal government, and this, they want to use this system and we use this system, and how do we get these two systems to talk to each other? And the same thing goes with EMR challenges. It's one thing to expand and take care of physical patients, but you also have to adapt your EMR or your electronic medical record to those spaces. You have to add rooms, add capabilities, add COVID testing and things like that to your EMR. So that's certainly been a challenge. I already touched on the telehealth and telemedicine piece. We did not have a very robust telehealth and telemedicine program here. We do, but we hadn't really used it in the way that others healthcare institutions have. And now we're starting to get on board with that. Testing locations. And it's been one of our biggest challenges is where do we test people? Where do we treat people? What kind of are those locations? And you see communications on there again. And I think the reason why you see I know the reason why you see communication on there again is you can do your best at communicating, but you truly can never communicate enough. You saw us in the news about PPE and staff worried about running out of PPE. Really wasn't that we were running out of PPE. It was that we weren't communicating effectively enough to our staff that we are okay. We have to put certain measures in place, but we are good. So again, back to communication we've done it well, but it's also been a great challenge to make sure it's effective and gets out to everybody. So that's kind of my contact information, and I know that we'll do questions after, but I hope that was within 10 minutes too.
Yeah, that was great. Thank you so much. All right, yes, lots of questions coming in and lots of really good information. You guys have certainly done a lot, and I just continue to marvel at everything. All I have to do is sit behind a computer and crunch data, so thank you. All right, with that, Dave. And Dave has warned us he may have some Wi-Fi struggles, so ask for your patience if that happens.
Good afternoon, everybody. Thank you for this opportunity to be on the panel. Have some, you all put me in a time crunch. I can get tangential, so I apologize if I do.
Take what you need, yeah.
All right, so, from a tribal perspective, tribal healthcare perspective, when this pandemic, sort of started, I think the one thing that, we had to look into was really situational awareness, and situational awareness from an organizational standpoint, any possible new needs that are arising related to the pandemic and anticipated needs. And as the first two presenters stated, even those that show up and pop up as, we learn more about the pandemic and the needs of our organization, patients, and communities that we serve. Then the third is implementation and communication to our patients, our communities, our stakeholders, tribal governments, tribal leaders, tribal council, and everyone in between. And so from the organizational standpoint, really what we've tried to look into was the design and flow, and a little bit was touched on that, talking about access points, screenings for organization. I remember when we placed up our screening tents. It was a weekend and going out and going shopping on the organizational credit card for makeshift tents, for heaters as we were sort of ending our winter, going into sort of the spring weather, but it was still cold. Then getting into the warmer weathers and needing some type of air conditioner for the staff that are out there. And then looking into the specific design and flow for the other departments, because within our organization, we have multiple service lines, medical, behavioral health, dental, pharmacy, radiology, et cetera. And, what are their process needs to be? Are they different? Dental took a whole different route than some of the other areas that needed some support, and dental was really one of the departments that we really had to sort of scale back on due to the aerosolization that the procedure causes, and trying to look at the data and information that's coming from ADA and helping that guide us on the direction and what we need to put in place in order to safely and effectively provide care to our patients, and then also provide that safety for our staff that is providing the care. The next we also look into the capacity of our organization. What can we do? What realistically is possible? Do we have other areas to build on that capacity? Thankfully for our particular organization, we just expanded into increase our space, 37,000 square feet in just the right time. It added to 20, I believe it's 25 exam rooms for medical department. And a radiology department. And so we had some space that we could utilize for this, for the pandemic. We had a area that was really put for staff to be able to play basketball, for us to be able to do yoga classes, etc., which was right next to our physical therapy department, which was going to be our new physical therapy department, and our hyperbaric treatment area. That quickly transitioned into our, what we call our acute care. Really, it was our pandemic and COVID response area, our way to separate our sick and well patients, if you will, or our possible COVID-19 patients away from our general public and population that were coming in, because the direction from the organization was that we weren't closing down. Healthcare needs don't stop in the midst of a pandemic, and we weren't going to close up our doors and not provide those services and needed services for our community that do have general healthcare needs throughout this pandemic. And so that was one thing that we looked into capacity, and unfortunately, that limited our ability to expand into our new services with physical therapy and hyperbaric. We looked into our staffing, and looked to see if we needed to make changes. And, as the pandemic started and communication nationwide came out, and, stay at home, don't seek medical attention, I think, in the beginning, unless it's an absolute emergency. And that impacted, I think, both our organization and even the community's health in general. And we've been dealing with that, I think, since the beginning, and trying to get the patients to, re-engage into their healthcare, let them know that not to wait until it's an emergency, because at that point we're dealing with a deeper issue versus trying to handle the healthcare needs as they come up, and not as they become an emergency. And therefore, since there were some decrease in visits through our primary care, we quickly transitioned our provider panels to more so COVID response. As patients were coming in wanting to get screened and wanting to get tested, and going through the process and allowing providers to be able to talk to them about the risk, the potential exposures, are they ready for or in the time period to be able to be tested right now, or is it not that time frame, since the day of exposure was today, they need to come back in 3 to 5 days, or unless they start to become symptomatic, then come back. Otherwise, you need to isolate at home. So we looked at some of those issues within the organization, how we can transition. It was mentioned about burnout. That was a big issue and concern that was brought up from our clinical staff, our clinical leadership, our DON, our CMO, our providers. And what we quickly did in response to that is we actually set up rotations where they rotated through our acute care setting back into primary care. And then they had a week off, to try and give them that transition, give them that time to sort of settle, resettle themselves, have some time with the family, and get ready for reintroduction back into the workforce. And so it really went from primary care to acute care, which was the highest stress, highest intense level, highest risk, and then a week off, and then right back into the rotation. Initially, when the cases started moving up within the state and even within our communities, is how we worked on the staffing and tried to prevent burnout for our staff as best as we could. Also with staffing, we did increase to Saturday and Sundays clinic. We're a Monday to Friday 8 to 5 operation. We expanded that need into the weekend, knowing that they might be some concerns about testing, contact tracing, guidance from the medical standpoint over the weekends. Our Sundays weren't really high productivity, and therefore we scaled that back to just only Saturdays, and we've maintained Saturdays throughout. Then, as I mentioned, talked about capabilities and looking at the separation of sick well, and then also, letting the staff know and the community, tribal council and our tribal government know that we weren't going to close, because we're here for the healthcare of our community, and in a pandemic when I think we're needed the most, if not us, then who? I think that this was our time to really be there for the community, show that we're there. And then going into new needs, looking at staffing again, locum staffing related to weekend shifts, locum staffing for our screenings up front, more nurses, MAs for the upfront to ask the questions, contacts, symptoms, and then do temperature screening up in the front. We had one entry for the employees and visitors, our employees, and another entrance for patients and visitors, all to get screened. And one thing that we did to help out the community as well as much as possible is we started screening all of the workers that needed to go into the community for the tribal government, and trying to screen them in the same manner that we did and do our visitors and our staff members, give them documentation so that way they could show that documentation to the tribal checkpoints, and they can at least be reasonably assured that we at least did a screening and they answered the questions, hopefully answered the questions truthfully, and limit our exposure or risk for the community. We also, I mentioned the tents, renting out, more sturdier tents in the beginning. We bought tents from Walmart where we could get them, and the weather quickly, the wind picked those up and threw those out, and had us go into a different direction. And so looking at tents, we brought in linen service for our acute care area. For our staff who were concerned about taking home their scrubs back to their home. And so that way they come in, if they're in the acute care area, they change into that linen. We have showers in that area. They can shower afterwards, put the linen into the bag, and then the service comes in and launders those scrubs for us. We also had washer and dryers purchased and set up and hooked up before we had the linen service put together. And so in the beginning, staff had a rotation of who was going to do that laundry actually, and taking care of those needs, so that way they felt they were safe for themselves and their families when they went back home. Then went back into our networks, and really trying to expand those networks and call on those networks. One of them was the labs, trying to understand where they're at, what are they doing, how are they expanding, what's the turnaround time for the results. What options do we have as a tribal organization? Here's what our needs are. This is why, just like everybody else, we need to know the results, so that way we can quickly isolate, quarantine. A big issue that we did run into is multi-generational housing on the reservation. You could have anywhere from 6, 8, 10 plus people living in the household, and you get one positive in that particular household. It's not out of the ordinary to go from one quickly up to 8 plus, just out of that one contact. And so then the issue with how do we isolate, how do we quarantine, etc. Then we get into implementation and communications changes, implementation, communication changes with regards to the staff, what direction are we going, why. I think that was a little frustrating for everybody in the beginning, in that one week we're doing this, and the next week we're changing as CDC guidelines come out and things start changing, and we start moving forward. At the worst, I believe, it was one day we're doing this, towards the end of the day we're doing something else. That's how quickly some of those changes were coming in the beginning. We talked about PPE, supplies were, very in high demand, and therefore trying to stretch out that supply, and how we're going to do that, and sort of project out what our supply is going to be needed, when our first order is going to come in, how we needed to be resourceful in that manner until the orders start coming in, is something that we had to sort of navigate through. Communication on these changes, the direction, information to our governing body or board of directors, then on to our tribal leadership, our tribal governor, our tribal council, who ultimately oversee the tribe and the community as a whole. And that communication and that discussion help lead to decisions that have to be made, hard decisions, whether it's a community shutdown, whether it's curfew, checkpoints being put in place, and them being able to do and make those decisions as a sovereign nation and entity, and for the best interests of their people, our communities, having that frank conversation. And then conversation and communication to our community, that is difficult in that we couldn't hold town hall meetings or gatherings, and that's normally how we would get the community, the discussion and information out to the communities. So as best we could, we had to go out to Facebook, our website, as best as possible. And even that, was a slippery slope, because as you move through the reservation, there's some areas that get reception and there's some areas that absolutely get none. And so that has been a difficult issue. And then coming to the decision about communication related to current numbers, how many positive tests that we've done. And that was really, a decision that we made within the organization on positive tests that were done within the organization, and not necessarily were reflective of positive cases within the community, specific community that we serve. But we thought it was, good information for the community to know that those are increasing and those are issues. Let's see. The other area was that was a difficult one, and that one that I think we had to sort of to figure out as we went on, once we started getting positive cases, is the behavioral health needs related to those positive cases in the beginning, doing checkups, screenings, for the behavioral health needs of those who are in isolation, and what concerns and issues they're going through while they're being isolated, away from their family, away from their kids, etc., was another area that we had to look into. I think that really the key during this pandemic, one of the key things that needed to be in place was the development of an emergency response team. Whether or not you had it in place, whether or not you had an emergency response plan, whether it was, something that was in writing to be able to pick up and get going, and who were the key staff involved. I think our organization, our CEO, did really well in sort of assisting the organization and the tribal government in putting that together, And this was a collaboration between the organization and the tribal government, medical staff from the clinic, tribal programs from the tribe, and then definitely the tribal government, i.e. the governor and lieutenant governor, and plus the tribal officials to really come together and talk about key issues when it comes to lockdown, when it comes to, we talked about entry points into our buildings and our facilities. That further went into entry points into the communities. Where are these entry points that people can go in and out of? And we want to sort of curb that, so that way we know who's coming in, who's going out, where our risks are, and what we need to do. And so, some tribal reservations did quickly go up and curb those entry points and really break it down to only one entry point in and out, so that way they can man that entry point and have some understanding of who's going out, who's and who's not. Screening at those entry points, as I mentioned, before shutdowns, what do those look like, and what does that mean for our communities? If we shut down the communities, then we need to understand that the people need to go out for groceries. Some don't have washer and dryers in their homes, so they need to go out for laundry services. Essential workers still need to go to work. How do we navigate that? Traditional events for our communities, that's been, a really tough one I can't imagine for our tribal leadership to go and say that we can't, we have to not do this. And in my lifetime, I think in my parents' lifetime, in my grandparents' lifetime, I don't think that there's ever been a time, aside from maybe the wars that were going on, that our traditional events never occurred. And to be in the position right now where these traditional events are on hold is a tough thing for everybody. Traditionally, and this is the way that we practice our tradition. None of this is written in books, that we can sort of learn it and look at it and understand it. It's all, word of mouth and practice and doing these traditional events. And, I think that's a real difficult issue for our communities to understand that. The emergency response team also went into looking into mass testing for our communities. How do we do that? Who do we reach out to? The state, Presbyterian has helped us out in that manner for these mass testings. How often can we do it? And now, sort of morphing into how do we do that on our own, and how do we, do our own mass testing to meet our needs of the community that we serve. But there has been issues with flow connectivity, as I mentioned, into the system, and registering patients and getting the paperwork documented has been some issues that we've been looking into. And of course, contact tracing. Quarantine, isolation. Thank goodness we had Buffalo Thunder to help us out with isolation of some of our patients, community members. That has been an issue, and not right now. Trying to look into a stand-up hospital within the reservation, because the concern of hospitals being at capacity with the increase. I think the other areas that are important is really adaptability from both the organization staff, leadership standpoint, the tribal government standpoint, and along with trust. We have to trust one another. They have to trust us as a healthcare organization, that with the communication and information that we're being related and communicated out to the tribal government in the direction that we're going. I think that's one thing that is great with our particular organization. We have a great trust relationship with our tribal council, our tribal leadership, and our board of directors, which just allow things to move real smoothly. The last thing is, the biggest issues right now are just the unknown. The unknowns of the vaccine efficacy. Once something does roll out, is it going to work? I have no idea. Is it going to be one round of the vaccine? Or are we going to have to do multiple? And if so, how's that going to roll out? Who's going to, you know, be on the priority list? And so we've already been working on those priority lists, how we're going to roll that out within our organization and communities, et cetera, which I know all tribal communities have been looking at, I'm sure at this point. Any possible spikes, increase in demand. I know we're in the midst of, you know, one right now, an increase in what those demands look like. And as I mentioned earlier, just the hospital bed situation right now is one thing that keeps me up at night. You know, we can't have a community member come up and say, okay, I'm concerned, I might, you know, be positive, they're symptomatic, we test, yes, you're positive. And what at the point if they are positive and symptomatic to where they need to be hospitalized, but we can't find any room for them. Last thing I want to tell my, you know, CEO, board of directors, tribal council, tribal government, and, you know, even our community members, we can't send you anywhere, you know. And so that's one thing that we are looking at right now is, you know, how can we reach out to our networks and, you know, do we have the capabilities of doing a stand-up, you know, hospital facility? We're in the works of those discussions, looking at the 20-bed facility, seeing if that is possible for our, you know, low to medium acute patients, and at least be able to take care of our patients in that manner. The unknowns with the PPE supply and demand, orders, lab supplies. You know, we have the ability to do the POC Abbott ID now and have a contract to order those supplies. And I've had it for months. We've put in our first order and have yet to receive our first orders. So it's difficult to be in that situation, and, you know, it really drives what we can do as far as testing capabilities, who we need to prioritize, how we prioritize those tests. And at times, understandably, that's difficult for the patients to understand. You know, why can't I get tested with the POC? Why do I have to do a lab send out and then isolate and wait for those results coming in to come in, et cetera? And you know, just the changes in direction as we, you know, learn more about COVID-19 is difficult from the organizational standpoint. You know, for our staff, 14-day isolation requirements, staffing changes, PPE protocol as our PPE supply goes up and down, you know, around and around, whichever direction it's going to go. What does our pre-PPE protocol look like? And what do we need to do? Thank goodness we, you know, we have a great infection control committee. We have an infection control director and her one staff member that does well. Our task force, you know, really looking at different protocols from a community, you know, standpoint down to the organizational level, and how we need to move, what policies do we need to put in place, and, you know, change from the organizational level. And they really help guide us in that direction on what the needs are, and really having an executive leadership team that's adaptable and really able to listen on those needs and make those changes. And the last thing is, you know, really the fake news, you know, as you well and can put out there, as it's been coined at this point, you know, has been a real difficult thing to sort of circumvent. Is this really real? Is it a political stunt? You know, and whatever else is out there that is really untrue and not to correct, but yet our community members, our patients, our staff are hearing it, seeing it, and how that relates to you know, difficulties within the operation, or how we try and treat our community and our patients. But in the end, we will be resilient. We will be strong. We will all get through this. And as I'm reminded every day within my house, from the picture that you see behind me from a Hopi artist that really commemorates the 1680 Pueblo Revolt for our people and our community. Just like those times and the times that we've endured, we will remain strong and resilient, and we will get through this. Thank you.
Yeah. That's great. Thank you so much, Dave. A lot of great comments coming in. I know I let that run long. It was just so interesting bringing that perspective that we don't always hear, from our tribal communities and our rural health communities. So it was just really interesting. So thank you, everybody. Okay, well, great. I think that was a great tee up to transition a bit to our panel. And the first question that I do want to ask, something Dave mentioned was, Dave, you're up at late at night thinking about where we're going to send our folks if they have to go into town and get a bed. So I want to talk a little bit about capacity. So my first question is for Doug and Robert. Are either of you, being one of the three major hospitals here in the state, are any of you relying on the predictive surge model that the state and Presbyterian and some of their partners have created and continue to update? Or, Doug, I know you're really big into data. How are you all, modeling demand or predicting surge and managing all of that?
I'll speak from our standpoint. We have a surge plan that's in place. Nancy Laster in our organization is running that surge plan, and we are keeping up with those surges and predicting units and moving to different units. We have moved much of our organization to negative pressure, working with facilities to create negative pressure rooms and to expand in those areas. So we have about 3 more phases ahead of us that we're still planned for to move to. And we have people on our team that are working with what we call the local hub and everybody locally with Presbyterian, UNM, and others to watch those.
So I would say yes. The answer to your question in short is yes. We are looking at the modeling data. Here's the thing about modeling data is it is particularly for this COVID pandemic, it's so wildly different. University of Washington University of Washington in the state has a model that differs a little bit from the Los Alamos Sandia National Labs model that the state is using. What I will say, because if you look at that back in May-ish, our peak was supposed to happen. It happened, but it did not predict that it was ICU that was going to be the problem back in May. This time, yeah, I predicted there was going to be a surge, but again, I think that they went back and saw, oh, okay, well, the ICU was the problem last time, so let's correct it a little bit, see if the predictive modeling, we can get a little bit better on the ICU. Well, they got a little bit better on the ICU, but then this time it's not the ICU patients that we're seeing, it's the medical surgical beds, just the normal admissions. So we're using it to guide us and as a tool. And like Doug said, we have our tier plans, and we're usually using more of what's real time and what's the need right now. Okay, do we need to stand up another medical surgery unit? Do we need to stand up another ICU unit? I think another thing about, again, modeling is that it's very useful. It helps us kind of predict and plan, but it had a hard time telling us that the northwest corner of the state and the tribal population of the state were going to be the most impacted back in May. And this time it's the central and southern part of the state. So it's useful, we're using it, but we're not hanging our hat on it, let's put it that way.
Yeah, I think it was interesting. I saw something, I think it came out of Johns Hopkins or one of those, and it said models are the most beneficial to us when we know the least, because that's when they can help us try to figure out where we're going. However, that's also when they're the least accurate because we have the least amount of information. So they start changing and morphing as we get more information. So it's almost like a paradox with that. So, well, great. We have a great follow-up question for Doug, kind of along that same vein. So, you're corralling all of these things. How do you keep your various well-intentioned leaders, they said in check, but to pull all in the same direction, so to speak, make sure everybody's on the same page and in agreement, as you're saying, this is what we're going to do and how we're going to move forward.
It's a good question, and it's not one that you. It's not a pandemic or a crisis moment solution, if you will. I talked also about the foundational elements of ensuring. I spoke a little bit about the Shingo model as an example. And in that model, you develop the foundational elements of employee engagement and empowerment. And those things are critically important so that when you do get in a situation like this, not only do people understand what their roles are, they understand what they're accountable for and what they need to do, but they're empowered to make those decisions and move forward. So how do you keep them in check, if you will? Well-intentioned leaders, in a crisis, you pull them all together, obviously. But prior to that crisis, if there is trust and there's and people are empowering each other to make decisions, then you allow people to take those accountabilities at different moments in time, and then from there, you just back their play, if you will, for lack of better words. We found that having a lot of people engaged right up front, where that seems nice, and it seems good that everybody has a voice and opinion and how things are going to get done. Very quickly, after a month or two of working 7 days a week, 12, 15 hours a day, people needed breaks. So that started to become a problem. And so you had to start depending on your peers. You had to start depending on others to make decisions, whether they were the kind of decision you would make or not. You have to back their play and you have to allow them to take control.
Yeah, it's I'm hearing it's a foundational skill. Basically, if you have that built already, then you're more positioned during the crisis to respond quickly and with trust. So yeah, very interesting. Kind of along those lines, these things come out of nowhere. And specifically with Dave, I'm interested, how did you all estimate what your efforts would take in terms of funding? That was a question from one of the audience members.
Well, thankfully for the corporation itself, we looked at the staffing models. We look at sort of cost, what our operation hours that we were looking at, and sort of project those out. We also then looked into a possible decrease and looked at the trends on what our revenues were looking at, throughout the beginning of the pandemic, how those, trends sort of decreased for primary care visits and, other departments. And our CFO really did a really good job on looking at the data and looking at our third-party reimbursements. And then we also had to look into what CMS expansions were related to the pandemic. They expanded some of their criteria to include more lenient regulations, if you will, of telehealth, not telehealth in its purest form. Then looked at other areas where we could sort of make improvements on. Right now, we're looking at having a tribal consultation with the state next week in regards to CMS regulation that allows us different billing opportunities for our pharmacy reimbursement structure, and really requesting the state to change into already approved a reimbursement structure that will definitely benefit our organization and help us to increase our third-party revenue back to what we had projected our revenues to be, or even surpass our projections of our revenue. So really just looking at those trends and trying to figure out where we can mobilize and transition our services to, trying to maintain our services and those open services, and really trying to let our community members know that our organization is safe. If they have healthcare needs, please come and utilize the facility and get taken care of, or making home visits if we need to.
Like, we'll figure it out. We just got to get it done.
pretty
Yeah.
much.
Yeah. Well, that's very interesting. I think the next question I'm going to direct for Doug and Robert, because Dave, I'm sure that you have experienced these. So the question is, have you encountered disparities within the communities in terms of accessing screenings, and what have you planned to address them, or have you seen that?
So I guess so can you expand a little bit as far as health disparities? Are you talking people's testing or seeking care?
I
Sure.
have a question.
What's that, Doug?
I have the same question as
Oh,
Robert.
yeah, sure. So I would assume, and Julian, correct me if I'm wrong here, have you seen any trends in terms of different communities having more difficulty to come and get the screenings, or more demand for screenings? Just any, any major differences that you've noticed, either between, community to community, or, group to group, anything like that, that may be impacting how people are either seeking or receiving care and or screenings?
So one thing that I can tell you is that we are identified early on. One community was the homeless population, and having them tested, first finding them, second having them, access to testing. What if they're positive? And what do we do, type thing. So that way they weren't building up in the emergency room or the hospitals. The city of Albuquerque took a pretty proactive approach, along with Department of Health, in opening up testing centers at the shelters. And then if people did test positive, segregating those populations. And then also, as it grew, looking at other spaces, hotels, things like that, you know, already have a low volume, because of the COVID pandemic. How can we utilize those? And so that's one population that we did notice, was that we had to take a little bit more of a proactive approach in reaching out to and making sure that they're taken care of.
You mentioned the hotels and some maybe alternative quarantine type sites. Is that something that UNM itself would have to pay for? Or is that something that was funding that was coming down from the state or federal funding?
Both. So it's coming from federal. So the city of Albuquerque has the arrangement, but they are working with the state and federal funding to help pay those hotels, so that they can quarantine in a safe place and not spread the virus.
What about you, Doug?
Yeah, I can add, based in that context, the screenings, there's been a lot of disparities in the screenings and how those are done over the last year. Starting out with some of the screenings as being, just screen everybody, and then screen people that are positive or have, not positive, but have symptoms, to kind of narrow that down a little bit. And then there were communities that we needed to get out to and do screenings. So it's one thing to have a screening area and expect everybody to show up in Albuquerque. So we set up a mobile group. People on my team set up those processes as well. I didn't even put that on the list when I did that earlier, but we went out to different areas and did screenings locally in areas that needed those done. So, it's a go as you learn as you go type of concept. And we've had different types of screening tests that we've tried. We've had different ways of doing those screenings, whether it be with people with symptoms or not. And I think New Mexico and all the hospitals have done a pretty good job of communicating that and ensuring that we're all following the same guidelines. But those guidelines change, and they probably change monthly. So.
Oh, monthly, that's generous. Yeah. Yeah, I think it's interesting that we've talked a lot about, the clinical aspect of this, of course. I'm curious, especially for the larger hospitals, but then I would love to hear from Dave as well. What other non-clinical impacts has this had on operations? In other words, have you all seen volumes drastically go down for a huge book of your business, or, are you maxed out? Like, what is it really looking like boots on the ground in terms of that? Because we're hearing in the news, the financial impact because all the elective surgeries, got restricted and stuff like that. So, what are we actually seeing on the ground?
Well, I'll just add a little something there, which is, when this thing first started and, we had 193 or 100 and 200 patients in the hospital, and we're way past that today. A lot of things reduced, right? So the surgeries reduced, the patients just go into the emergency department. Just people were scared, and so volumes went way down. And so, fortunately, we had some ability to react to that. And then once we started hitting the second phase, like we have right now, our hospitals are pretty much full. And so it's a totally different world today than it was back in May, because our hospitals were full. We actually have employees that are getting COVID now, and they're gone. And so our staffing is really challenged. And we have a lot of things going on in the hospital. So I think, and this is just a soapbox thing, but I think we had a lot of people alert and attentive to this issue back in May. And I think a lot of people, I talked to the common people out on the street, and that don't know much about what's going on in healthcare. They have no idea what kind of surge we're in right now. And they have no idea that it's 4 times worse than it was back in May. So, yeah, that's just my tidbit. Robert, what do you got to say to that? Because I bet you've got a few things.
So regarding the financial piece, I think the first financial piece for us was, well, we're just going to do it. We're just going to suck it up. We didn't know that there was going to be CARES Act funding or anything of that nature. It was, this is a disaster. We've got to take care of patients, and we've got to just do what we need to do. They can't, like Doug said, cancel surgeries. All right, that's a hospital's greatest revenue generator right there. But then, okay, now that we cancel surgeries and there's crickets in the OR, we still got to do emergency surgeries and things like that. But what are we doing with those people? Okay, what, we don't just send them home. We found things for them to do. We sent our finance people in a tailspin, I'll tell you that, in that, are we going to recoup any of this cost? I have no idea. But make sure you build it out, make sure you bill it correctly. And we weren't even doing that at the first. But again, our non-clinical staff were kept very busy in almost a guessing game. Our IT staff, kudos to our IT staff, because I think they were getting directional changes by the minute. Oh, add this order. Oh, no, don't add that order. Change it to this. Oh, wait, we need this piece of data and we needed it 2 days ago. Oh, because we need to meet this compliance. And so our non-clinical areas have really been working extremely hard, or with ever-changing information and ever-changing on how we do things. Clinical care, yes, we talk a lot about it, but it is those folks behind the scenes that are, and students too. We have a lot of students. What do we do with our students? How do we make sure that they're going to be able to graduate and things like that? So.
That's interesting. Dave, how about you from your perspective? Probably a little bit different from some of the larger facilities there in terms of what other sort of non-clinical impact that you've seen.
Non-clinical, a lot of what we've seen has been sort of the decrease in services and decrease in volume, what that anticipation is going to look like, and knowing that the direction from the organization is we're not stopping, we're continuing on with services, and all of the non-clinical support services that we have, we must still remain in place We need, when there was a talk about working from home. Of course, maybe some of our billers or coders, some of them could possibly do that. But what that would require is some laptops, and laptops were in high demand due to schools, and the anticipation of the transition of schools going to e-learning and stuff. And we could not even get a hold of enough laptops. So even if we wanted to send our non-essential support staff home and say, hey, you can work from home, okay, maybe so. Then the other aspect that we had to look into is our cybersecurity. Do we have the availability for them to work from home and ensure that that is a secure line and ability that will prevent from our system being hacked, etc. And be in a worse situation if we are hacked and don't have the ability to operate our EMR system as normal. And so some of those changes that others were able to do, we weren't able to because the infrastructure wasn't there, so to speak. But in the operation standpoint, we kept it. The direction is we're still moving ahead. And moving ahead in regards to right now, the best thing for our organization is to transition our EMR off of the typical IHS and Tribal 638 system. And through the pandemic, we're in the midst of that. We're looking at transitioning in the beginning of December. And we've also been in the midst of getting accredited for our facility. And we're looking at having that date come up the end of December. So amidst all of the pandemic issues, operations, both clinical and non-clinical, are remaining the same, are remaining pushing in the same direction. And always sort of keeping that in mind is that our healthcare system and the reliance of the healthcare needs of our community still remains constant, and therefore we can't necessarily stop in the midst of a pandemic. We have to figure out how we make it work and continue to move forward. And do our best in that manner.
Yeah, well, accreditation and, migrating systems, those are not even easy on a good day, outside of a pandemic. So I can only imagine. Speaking of sort of this emergency response and how we deal with it, I'm interested, Doug and Robert, a question around business recovery plans and extreme crisis. So the question is, did you leverage any of your existing business recovery plans in order to formulate your COVID activities? In other words, how much did those actually come in handy and get put to use? And then a follow-on I'd add to that is, did it highlight a lot of gaps, in those plans that maybe you'll start addressing moving forward that's a little different than how maybe you did it in the past?
Yeah, I'll just throw out a couple of things there. So business recovery plans. Yeah, we put business recovery plans together. I want everybody to understand, and I guess you all know that nobody's been through a situation like this in our lifetime, right? So we can plan for the recovery of business based on this situation as best you can, but yeah, there's a lot of on the fly change to business recovery. One of the things that has been really significant for us and helpful for us is our health system is part of a larger health system nationally, 30 hospitals nationally. So the coordination and the collaboration of those 30 hospitals together, we have hospitals in New Jersey that back in May were much worse off than we were. So we had we were on phone calls every single day, working with them to understand what their needs were, and knowing that those needs were coming our way. And so we had a lot of predictability based on that. And we also did a lot of work to support them. So we were shipping ventilators across the country and people to help our other hospital systems. And so that's part of the business recovery, which is, as we're all getting hit, we were able to collaborate and combine those resources and supplies that we needed across the board, supplies, especially PPE. Our PPE decisions were made on a corporate system level at the 30 hospital level, if you will, that allowed us to share that stuff and work together.
Yeah. Robert, what would you add to that? Because I'm sure that's recovery and disaster plan is a big part of your role there.
Yeah, business recovery planning. I have to say that it's still ongoing. It really is, and it's still evolving as things heat up in the clinical care world. And not knowing exactly what the future is going to bring to us. We are working diligently to make sure that, okay, yeah, we have a business recovery plan, but a business continuity plan, but we might have to do some things different. We can't do the surgeries we want or need. We can't do some of the IT things that we need to do. But yet we're going to do this over here because it's what we need to do right now. So it's an ongoing evolution, I would have to say. As far as leveraging those and using those, yes, but at the same time, they're changing every minute.
It's interesting you mentioned, you can have all the plans in the world, and then there's something unforeseen is going to come up, like you just said, okay, well, we actually can't do surgeries now. We didn't anticipate maybe, all of our revenues dropping, like, so there's always something unanticipated. So particularly for Doug, I'm curious, I noticed when you were flipping through some of those configurations of the cars and everything, some of them changed quite a lot. So was there like a huge unforeseen, something that came up that you all hadn't even thought about that sort of made you all have to pivot pretty quickly?
Oh, yeah, like 6 people showing up in one car to be tested, right? Or a bus showing up for testing.
Gosh.
You first initially plan that somebody's going to come in, it's going to be one test per car. Yeah, no, it wasn't that. So obviously that blows away cycle times and process. So that's an example. Changes in criteria, like I said, testing everybody versus testing people that are symptomatic. Now that we're testing, you start out testing everybody, and now we find out people are not symptomatic. So how are you going to get them out of the line and move them out of the line? Yeah, it's simple, but it's a big deal. And then we really didn't know right at the beginning how critical this was going to be. And so what type of staff did you need available? And we started off with pretty heavy staff with physicians and everybody out there, because we didn't know what kind of crisis we were going to have. And, we did have a couple of significant crises that needed to be addressed by a physician immediately, emergently. And so we were glad we had that set up the way we did. So yeah, there was just a million iterations. I'll just mention Steve Grego's name again, working for me, but he did a lot of work on cycle times and process for that. And we changed from 2 cars to 3 cars going through one area. And how long does it take to screen a patient versus how long does it take to swab a patient? And looking at those, so you might have 4. It takes longer to swab a patient, so you might have 4 people swabbing and 3 people screening, and really setting up the labor that way so that it would flow. But yeah, there was lots of changes throughout it, Stephanie.
What about you, Dave? What was the biggest, unforeseen wrench or something that popped up that you all maybe hadn't even anticipated or thought of because you were just moving so quickly?
Oh, I think there were multiple. But I know some of the big issues that we did run into is when we did have a positive is just trying to quarantine. Where do we send them? What do we do? Especially from the tribal perspective, dealing with multi-generational housing and maybe not the ability for one section or one room to be able to be utilized for the person who is positive. Then what? Where do we go? What do we do? As I mentioned, thank goodness for Buffalo Thunder and accepting positive and even non-positive that just want to isolate and feel that they had a contact or high risk. to help mitigate the spread, that helped out a lot. Another area that we really was unseen is positive patients with substance abuse use. That was one that was really difficult because we could not find, in the beginning, we could not find a place that would take somebody who could possibly go into withdrawals that was COVID positive. I mean, we looked and searched. I think finally we found, one location within Albuquerque that was transitioning into that. We're able to get somebody there. But substance use and abuse and that history, it was difficult to place those patients, and also difficult to, as Robert had mentioned, for the homeless, keeping track of where they're at, where they're going, how they're going, where they're visiting. And that was a difficult one for both the corporation and tribal organization, or tribal the tribe, to sort of get a hold of and grasp. The tribe also did well with putting up mobile units, mobile trailers, and setting those up so that way we can isolate positive patients in these areas. We had a modular right next door that we converted into sort of an isolation area that we can house people, but those quickly fill up really fast. And so I think the substance use and then the placement of them when they were COVID positive was difficult. And then the other thing, once again, I know I brought it up earlier, but the behavioral health needs for the positive patients and checking up, following up on them and making sure that they're okay. Do they need support? What do they need? Especially when we transition them an hour away from the reservation, and how do we get them their needs, whether it's medication, whether it's other needs that they might have that the facility might not necessarily have, was a difficult one, and trying to keep up with those behavioral health needs in the contact tracing, calling, having our staff call up and follow up and do what was needed.
Yeah, that's amazing. Well, great to hear right before Thanksgiving's coming up, and I'm sure everybody's wondering if they should, get together with their family, and there's different varied opinions. What would you all recommend for us? Dave's shaking his head no.
Yeah, don't, please. And that's a really hard one. I constantly scream at the TV when they ask this on a national level and say, well, you could do this, no, you can't. Thankfully, finally one immunologist, I think from out east, finally answered it and said, unless you have the ability to test people as they come right in to know that they're not positive, and even that is not a best case scenario, don't do it. Stay at home with your immediate family, and that's something that we're trying to push with the tribal government and let them know that this is the communication that we should put out is don't go back and forth between household, don't have sleepovers, don't have gatherings, just stay with your immediate family. As difficult as that is, especially even with tribal communities, we're used to gathering, we're used to coming together, from cultural events to holidays to even our worst times, from ceremonies that involve deaths and moving in that direction. It's really difficult, but it's a no.
I see Doug nodding in agreement, so I'm gonna take your word for that. So thank you all. All right. Well, any last, you have the platform. Any last words before we adjourn? Do you want to get out? Any messages? All right. Well, thank you guys so much. This was a resounding positive feedback in the comments, and just really informative. I appreciate all the time that you've spent with us here today. We will be posting this video on the New Mexico HIMSS YouTube site. I'll send that out to everybody, including our panelists, if you'd like to share it. But again, just huge thanks from the New Mexico Healthcare Execs and the New Mexico HIMSS chapter. This was wonderful. Thank you so much.
Thank you.
Bye.